Welcome back to House Healthcare for 3:50, 3:40 something in the afternoon. Our schedule got pushed back a little bit today because we were taking testimony this morning that was frankly riveting, or at least I thought it was riveting. So some of our witnesses got pushed back. So we thank them very much for coming back. So first up, we're gonna we've got Michael Barber from Green Mountain Care Board. So if you'd like to join us up front. We have not done a complete walkthrough of this bill. In fact, we've barely done any walkthrough of the bill. So there are some sections that concern the Green Mountain Care Board. So that's what Michael's here to talk about.
Good afternoon. For the record, Michael Barber, General Counsel for the Green Mountain Care Board. Thanks for having me here this afternoon. This testimony won't be riveting. I apologize.
Well, you're talking to her. You might.
Pretty dry, I think.
Help yourself.
Yeah.
So obviously reviewed the bill, discussed it with the board chair, the executive director. I'm happy to share some initial thoughts. I do want to just caution here at the outset or set up at the outset that the bill deals with some pretty complicated issues, nuanced issues, and does so at a pretty granular level. And some of these issues are a bit outside of the Green Mountain Care Board's wheelhouse, and that, physician autonomy and day-to-day practice applications that we don't have a ton of insight or expertise into. So we are quite interested, as I'm sure you guys are, of hearing from other agencies, other entities that might be affected by this bill, and would like at least the opportunity to come back in at a later date after the kind of testimonial record develops a bit. So
Great.
with that, I'll get into it here. Going to jump around just a little bit, if that's okay. And I wanted to start with the sections that would render non-competition agreements, non-disclosure agreements, and non-disparagement agreements null and void. So we support those provisions. Sorry. Section 9533D, which starts on page 15, line 4. As well, it's in these are in two different sections of the bill. There's also section 9534B, which starts on page 18, line 18. So the different kind of subjects, but both of those provisions render these non-competition agreements, non-disclosure agreements, and non-disparagement agreements null and void, with some exceptions, caveats. So we do support that. In particular, we think that the prohibition on non-competition agreements or non-competes is a good idea. By definition, these agreements are designed to limit competition. Competition is something we generally need more of in Vermont. The American Medical Association has some literature on this that says that non-competes can effectively prevent physicians from leaving a practice, particularly if that practice has a large geographic footprint or is in a highly concentrated market like we have here in Vermont. The AMA also warns that non-competes can harm patients by compromising physician autonomy. And they give an example of, a doctor with at-will employment terms might be more reluctant to advocate for patients or speak up on matters that might negatively affect patient care. If, their employment is at will, they can be terminated at will, and that termination triggers a non-compete that would effectively prevent them from practicing elsewhere in the state. So, a number of states have enacted laws to regulate the use of non-competes. The language in this bill appears similar to some other bills, particularly Oregon is the one that looked very similar to this bill.
I know this isn't your domain, but the board does do hospital budget review, and you have regulation over hospitals. Do you happen to know if any of our hospitals in Vermont currently use non-compete clauses in their contracts?
You know, it's not something that I have insight into. That might be something that
We'll ask the hospitals.
the chair, I'll ask Owen when
Yeah.
I see him again. We also support the limitations on misleading advertising.
Where's that?
Found in section 9533E, starting on page 16, line 5. Not much more to say there.
You support this?
Yeah.
Okay.
And now I'm going to skip ahead a bit to the sections of the bill that deal with the board primarily. So it's regarding submission of information on ownership and control of healthcare entities and reporting that information to the public. So starting on page 20. Got a new section of law here, 9541, which would require healthcare entities, which is maybe one of the definitions you covered earlier. It would require them to report information to the board and the attorney general at least once every 2 years. And upon consummation of a material change transaction, which is another defined term. And then moving on to page 24.
So was that, and you want that or not want that? Yeah.
I'm going to address these together.
Keep in mind that we're not lawyers and we haven't seen this language yet.
Sure. So
You're gonna address both?
I am going to address both,
Okay.
kind of hand in glove.
Okay. What was the other page? 24.
24, section 9542.
Okay.
So this would require the Green Mountain Care Board on or before February 1st, 2027, and every 2 years thereafter to post a report on the board's website, kind of using that information that is received from healthcare entities under the previous section. The report would need to include, among other things, changes in ownership or control for each healthcare entity, changes in tax ID of each healthcare entity, the names, addresses, tax ID numbers, business structures of the healthcare entities, as well as their affiliates, subsidiaries, management services entities. And lastly, an analysis of trends in horizontal and vertical consolidation disaggregated by business structure and provider type. So again, these two sections are working. We're getting this information at least every 2 years and upon consummation of a material change transaction. And then every 2 years, we're preparing a report using that information and posting it on our website. At a high level, I want to say that this seems consistent with the approach that some other states have taken to, make this information public, increase the transparency around it. And we very much appreciate the shift in focus from, review of these transactions or the ability to review these transactions to reporting and transparency. That said, I don't want to minimize the work that this would be for the board because I don't think it will be trivial. And I suspect that the volume of data we get could be quite high. It's a little tough to know at this point because it's not something we have insight into. But there's a couple of reasons I say that. A healthcare entity, you may have covered this earlier, is defined quite broadly. And it includes healthcare providers, healthcare facilities, provider organizations like accountable care organizations, management services organizations, pharmacy benefit managers, health insurers. So it's a pretty broad scope of entities. There are some exceptions, but for the most part, these healthcare entities would need to report information as long as they have total assets, annual revenues, or anticipated annual revenues of at least $1 million, which is a pretty low threshold, $1 million. And the list of material change transactions, that's, like I said, another defined term, is pretty broad as well. So it's a broad scope of people, transactions that would need to be reported. So I think the volume might be quite high. I think we can manage it, but there is one provision that we would ask be stricken. So that's the one suggestion I do have for you. And that is on page 25, stricken or revised. Page 25. Lines 3 and 4. This is, like I mentioned, this is part of our reporting requirement, where we would have to report an analysis of trends in horizontal and vertical consolidation, disaggregated by business structure and provider type. Most of the other provisions that we'd be reporting, the information we'd be reporting, is kind of aggregate data from what we get. This requires us to go beyond and analyze trends. I think we're concerned about whether we have the resources and staff to do that. So we would like that to be stricken or modified in some way.
Do you have suggestions over modification, or would you prefer it's just stricken?
I think for now our preference is stricken, but I do plan to talk with the healthcare advocate about this and some other issues,
Yes.
and we can talk about that as well.
Yeah, of course. Would the healthcare advocate like to chime in?
Just want to say, healthcare here, just want to say, I feel confident that the board and to a reasonable place that works for the board.
Great.
And then I'm just going to talk about the other provisions of the bill, the prohibited transactions, which is, well, I don't think you need to go to each of them, but prohibited transactions, corporate practice of medicine, corporate entities being permitted to employ physicians. There's a number of other, like the meat of the bill. I think we're still working through. We have a number of questions that we've shared with the healthcare advocate. We're going to discuss later, and I think with Ledge Council as well, just about how these provisions work together, whether there may be some unintended consequences, whether they make sense. I don't think it would be the best use of your valuable time to go through those in detail. They're pretty technical. You haven't had a walk through. I'm happy to come back, and if I still have questions that I'd like to share with you or concerns, but at this point, I think we're still kind of digesting those pieces.
Okay.
I'll leave it at that. I'm happy to answer.
Can I, just because I'm making notes here, in general, other than the administrative burden, putting together a report every 2 years, is the Green Mountain Care Board in favor of subchapter 4 that you noted for us around reporting of ownership and control of care entities, and then the sharing of information to improve? Are you generally supportive of both those sections except for 6 on page 25?
Yes, yes.
And noting that it will take.
Yeah, I'll
resources.
just put a yes. With a caveat, I haven't spoken with the actual people who will do
Okay.
work.
Oh, they're not gonna support it.
So they're, just figuring that out, I think, but yeah, but generally, I think are supportive of increasing transparency around that. If we need to be the vehicle for that, provided we have the resources to do that, I think you need to dig into that a little bit more, but I don't anticipate.
This one here too, they support that?
Yes, I do.
They support.
Yep. Okay, do you want to pivot to? Yeah, I'm sorry, you wanted to think about some other things a little bit more, I think you said, around
Yeah,
prohibited practices.
yeah, I think we'd like to speak with the HCA about some questions we had in Ledge Council about how some of these provisions work together and potentially intended consequences, and we can come back if there are still questions and concerns around that stuff. But I don't think it'd be the best use of your time this afternoon to kind of walk through those in detail, if that makes sense.
Can you just speak a little bit louder?
Oh, sure.
Sorry, thank you.
I actually had a question. During the budget review process this year, there were several instances of identified services that hospitals are contracting out to other entities. Like in some cases, hospitalists in one hospital were contracted out, emergency doctor, ED physicians. In general, are there things in this bill that would be helpful so that we could have a little bit more illumination on this, I guess, or clarity?
Essentially, some of the reporting would touch on that. I can go back and review that with that in mind. I will say that there is a bill that would address the outsourcing issue. I can't remember whether it's S-189 or 190 or,
From the Senate.
but there is a bill that specifically addresses that issue that arose. Yep.
We'll see if we get that. Thank you. Yeah, anyone have any questions? I'm sorry, didn't have any questions, sir? Thank you. Oh, did you have a question?
Say that it is in the outsourcing has many sections in S-190, and tomorrow morning, Senate Health and Welfare taking that bill.
Oh, okay.
Stay tuned.
Stay tuned. Thanks. Hey, Todd, would you like to come on up? Thanks for coming back.
Pleasure.
Spend your whole day at the State House. Super fun.
It's a long commute for me.
Yes.
Yes, of course. No, it's a challenge. Good morning. Nope.
After.
I just-
Good evening, good
I'm
evening.
in again. Good afternoon. For the record, Todd Delos. I'm the Director of Policy for the Attorney General's Office. And thank you for having me in. Thank you for engaging in this important topic. And I know you've gotten a ton of information today, and I also know you haven't finished the walkthrough with Ledge Council. So I'm going to, similar to Mike Barber, I'm going to stay fairly high level and just kind of give you a rough take of where the AG stands on this bill. But by way of background, along with being an AAG, in a previous iteration, I worked in the Agency of Human Services and engaged in some of the transactions or reviewing some of the transactions that I think this bill is really seeking to address and analyze. And I think it is a really important area in terms of the healthcare sustainability in the state, really looking at how these transactions occur and recognizing that on the one hand, we need to be ensuring that the medical judgment is what is driving care. And on the other hand, recognizing that investment in healthcare is an incredibly important tool for the sustainability of our health systems. So with that as preamble, we support the broad policy goals of H583. They are a little outside the traditional lane of the Attorney General's office, and I'll get to that. But the goals of transparency, certainly of paramount importance, especially in this space. And the goals that were laid out this morning by the healthcare advocate in terms of how to ensure that transactions and certain degrees of control that occur within the healthcare space are understood by the players and meet the policy goals of the legislature. So when I talk about the lanes of the Attorney General's office, I haven't been before this committee.
I think so.
Last year on
Yeah, you were here
that's
once.
28.
Oh, yes.
But not about something like this. So, obviously we have work in the environmental space, in the criminal space, and a lot of our work is in the consumer space. And we provide oversight, regulation, enforcement in areas as diverse as lead paint, fuels, nonprofits. We don't do a lot of work in the healthcare space. And I think it's important to understand that that doesn't mean we don't have the ability to enforce our existing consumer protection laws. And that's actually what the bill proposes, is to recognize these as violations of consumer protection. But with any enforcement action, so the criminal space is the easiest one to kind of understand this analogy. If a law is broken, if there's some kind of crime committed, law enforcement is first and foremost the folks who investigate that violation. Law enforcement then creates a case and brings it to a prosecutor, be it a state's attorney in Vermont or the AGO. It's almost always the state's attorney. And the state's attorney then takes that case, that investigation, and acts upon it and prosecutes the case. The analogy is in the consumer space. We have maybe 2 investigators, maybe 3, who do this investigation, who look into unfair and deceptive acts and practices in commerce, working with AAGs, assistant attorneys general. They then build a case and may seek an enforcement action there. What I see in this bill and what I think is contemplated, and I'm happy to keep working with the healthcare advocate on this, is that in some ways the care board will be the repository of that information and will provide a measure of, but I do not want to speak for the care board, a measure of that investigation and sort of flagging where there may be concerns in these transactions. And then the Attorney General's office, who also will get the same information under the bill, could take action in that space. I think what is unclear, and the care board just spoke to this, we don't know what the volume of this work is going to look like. And I think that is going to be a crucial area for us to understand how to take on this work. I will say I recognize these transactions have occurred in Vermont. They are likely to still be occurring in Vermont. And I think what I don't know is how much person power the Attorney General's office is going to need in this space. And that's something that we can look at, again, continue working with the board and others to assess those needs. But I think it's important to just say that that's maybe the animating space that we want to investigate further and look at in this bill.
May I interrupt you really briefly? Do you feel as though, I mean, this is already occurring in the state. We know it's already occurring. Do you think at least the process of having this in law, that these are prohibited practices, would at the bare minimum be a deterrent?
That's a great question. I do think so. And I think there will always be scofflaws and folks who skirt the law or are unaware of it and need assistance complying. But I think needing to touch base on some of the language, and I've spoken with the care board and some other folks, and I'll talk about that in a minute. I think there are some areas where we'd like to make some recommendations on changes to the language. Again, you haven't walked through it, so I don't want to presuppose how Jen's going to walk you through it and explain things, but there's certain areas that I think could be clarified a little bit. But generally speaking, yes, I think most reputable organizations will comply with the law. And that in and of itself will prevent a degree of whatever prohibited activity you may decide upon actually occurring. It's a very fair point. I think the other piece that I would flag is that there may be a resource need for the AGO, but we're also looking at the ways in which existing structures within state government may respond to some of those needs. So whether it's how the care board responds to the information they get, I think it's also probably valuable, and I respectfully would suggest to the chair and the committee to have the Department of Financial Regulation come in to talk about it. I think there may be some overlapping authority there that could help provide some clarity, and I think they're a really important partner in this space as well. They understand the insurance market. They understand a lot about elements of the healthcare market, and I think that's going to be an important partnership in any kind of regulatory structure that comes out of this. And as I said, we're more than happy to work with the healthcare advocate on some of the littler pieces. The one maybe area I would direct your attention in terms of specific language. So the AGO, the Attorney General's office, really only appears in the bill mainly in the enforcement section. We get the reports the same that the care board gets, and then looking on all the way on page 25 in enforcement of the chapter, it's a fairly simple cross-reference to the Consumer Protection Act, which is 9 VSA Chapter 63. I think it's important, and I'm going to be careful not to walk through it. But there are some important deviations from that in terms of the level of penalties that we're able to seek. I think that's important. One item I would raise for consideration of the committee is there are certain prohibitions suggested in the bill that if you had, for example, not presupposing how the bill is actually prohibiting actions, but if you had a non-medical person in charge of medical decision-making, understood very broadly, that could be considered a violation. And we could go after somebody and say that's a violation. Every decision that person makes is a violation. Every day they make a decision is a violation. And that's a pretty significant penalty that'll likely change behavior. What I haven't seen, and am happy to have it pointed out by others, is if there's a prohibited transaction, so not an operational determination, but a transaction where a leverage, some kind of private equity engaging and purchasing a healthcare entity in Vermont in a way that's prohibited by the bill law at that point. I'm not sure how we unwind that. So we could say that transaction was a violation, and there would be penalties for that if we could prove it. But I'm not sure there's something in the bill that would then require that to be undone. Now, maybe there's language that says every day that that entity exists after the prohibited transaction is a violation of the law. I'm not sure the language is there, but just something to consider is, and I am not well-versed in corporate law, but I'm not sure how you would frame up unwinding. But I think that's probably what the committee or certainly the sponsors and advocates for the bill are looking for, is some way of preventing that level of control and potentially damaging actions by those entities that are owning the healthcare practice. Am I making sense?
Yes, so basically what you're saying is, like a medical decision-making, every single time you make one medical decision, that's a violation in itself. But just the owning is one, and you're saying that maybe we can get to a point where maybe every day you own, it is.
Yeah, I think there's sort of two ways to look at it. So the operational, we consider anytime there's an unfair, deceptive act or practice in commerce, and we can identify it and prove it, we can say that's a $10,000 fine for each occurrence. When you have a financial or a real estate or an operational, not an operation, but that kind of purchase and sale, right? That you sign, that's the transaction.
One time.
The fine happens, it's under the draft language, it's $100,000. That's a fairly significant penalty, but on a multi-million-dollar transaction, maybe it's not. I certainly would be for me. But I'm not sure then that we get to the point that the committee wants is, which I think is to prevent that level of marketplace interaction. And so I would just say there may be an interest in figuring out how if there's authority to unwind or otherwise undo a transaction. And I don't have an offer on language around that, but it could be that, or as you said, Chair Black, it could be every day that you continue to own it is a violation.
Yeah.
And then the financial penalties become certainly a deterrent to continuation. So those are the main points in terms of the bill. And I think, as I said, happy to work with folks on language, some of the concerns that we have. And then, just being transparent with the committee that I think we'll need to determine over time what the volume of work is and how we respond to the volume of work.
Any questions? Yeah, go ahead.
I'm not quite sure how to ask it, but do you have any concerns that this bill, as it's currently written, would prohibit or dampen healthcare innovation in terms of partnerships and mergers for sustainability purposes?
Yeah, I would certainly defer to folks who are more versed in the current systems of care and the strains and stresses they're under. But I think there is some language in here that it would be friction within the system, right? And I think anytime you regulate an industry, that's a degree of friction. But I think we usually say the balance is better than the detriment, the benefit, I should say. In this instance, I think, again, I want to be a little careful because I think it's worth further conversation with the healthcare advocate and the committee around maybe some tweaks in the language that could limit that. And I think it would also be beneficial to hear from arguably the regulated entities under this, because they would certainly be better able to speak to that question. But I think there are areas where some of the language would suggest regulation where I'm not sure the committee quite wants there to be regulation, and that would impact innovation. I think it's solvable.
I have a question that I'm posing, and it's more than I'm posing the question, but you can just answer yes or no, or not answer at all. Posing.
That's an option.
That's an option. You can say, I need to think about that. You were listing, what did you call them? Basically the types of things that you deal with at the AGO. Consumer protection, water, I think environmental. But you don't typically move into the healthcare space other than in consumer protection things. I think you.
Yeah, I think there are a few areas where there are S128 from last year is an example of a consumer protection in the healthcare space that's around truth in advertising and healthcare services. But it isn't the degree of, I think Sam's testimony and Mike Fisher's testimony this morning is very helpful. Like, these are incredibly complex transactions. That's really what I mean. We have good litigators. We have folks who are really expert in the field of deceptive and unfair practices. And here we're really looking at some very complex corporate structures. And that, just to be transparent, that is not an area that we regularly practice in. And so there's language in the bill that suggests the ability to go get expert help. And I have some suggestions around tweaking that a little bit, but I think it's important. This is not sort of the core work of the AGO.
So the question I'm posing is, in the state of Vermont, we're now spending well over $10 billion a year. I always like saying $1 billion a year on healthcare and healthcare related services and all these providers. And we know that we've had issues. And we're also dealing with Vermonters' lives here. And this isn't, I got sold something bad. This is life and death in a lot of cases. Don't you think we need to devote resources to it?
Yes.
Okay, that was the yes, no, or let me think on
That was pretty
it.
straightforward.
I did that,
Thank you.
Okay. That was all. Any other questions? Didn't think you were just gonna. Yes. It's important work.
It's important work, and I mean, at the risk of saying more than you were requesting, but now I'm talking. And that may be what we need to come back to this committee about,
Okay. Thank
What
you.
is,
resources.
that?
Thanks, Todd.
Very
Okay,
welcome. Thank you all.
we're done for today. Thanks, everybody, for coming back. And we can go